Hi there, I'm Sujata, founder of Grace USMLE Tutoring. I partnered with Achievable to create a comprehensive USMLE Step 1 course for medical students. It combines my years of USMLE tutoring experience with Achievable's powerful software. To learn more and gain access to a free trial, visit achievable.me. Hello everyone, this is Sujata, founder of Grace USMLE and USMLE author at Achievable. In this video, I would like to go over some concepts related to congenital heart disorders. The congenital heart disorders can be divided as cyanotic versus acyanotic heart diseases. The cyanotic heart diseases can be classified as the 5 T's. The 5 T's stand for tetralogy of Fallot, transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous return, and tricuspid atresia. The important acyanotic congenital heart disorders are atrial and ventricular septal defects, patent ductus arteriosus, and coarctation of aorta. Let's discuss the acyanotic congenital heart diseases first. Ventricular septal defect is the most common congenital heart disease. In most cases of ventricular septal defect, the defect is in the membranous portion of the interventricular septum. In many cases, ventricular septal defect or VSD is asymptomatic. In some people, it may become symptomatic as recurrent lower respiratory tract infections. In rare cases who develop Eisenmenger syndrome, cyanosis may develop in a ventricular septal defect. Physical examination shows a harsh pansystolic or systolic murmur at the lower left sternal border. Cardiac catheterization is the gold standard for diagnosis, and it will show increased oxygen saturation in the right ventricle and in the pulmonary artery. There is an increased risk for infective endocarditis in all cases of VSD. Atrial septal defect or ASC can be of multiple types. The most common one is patent foramen ovale. Secondum type of ASD is the most common congenital heart disease which is diagnosed in adults. The presentation of atrial septal defect or ASD is very similar to ventricular septal defect. Many cases are asymptomatic. Some cases may present with frequent lower respiratory tract infections and slow weight gain in childhood. In adulthood, people with patent foramen ovale or atrial septal defect may present with paradoxical embolism, meaning a deep venous thrombosis which can travel across the heart and result in a stroke. There is a fixed split of S2 on physical examination. In some cases, there may be a systolic murmur in the upper sternal border and sometimes a mid-diastolic rumble in the lower right sternal border. Cardiac catheterization will show increased oxygen saturations not only in the right ventricle and the pulmonary artery, but also in the right atrium. Patent ductus arteriosus or PDA is often associated with congenital rubella syndrome. The ductus arteriosus in fetal life connects the pulmonary artery to the aorta, and it is abnormal for the ductus arteriosus to remain patent after birth. PDA presents with cardiac failure, growth retardation, and frequent lower respiratory tract infections. Over time, pulmonary hypertension may develop, which may cause a reversal of shunt in the patent ductus arteriosus, causing deoxygenated blood to reach the lower extremities, leading to a differential cyanosis. In differential cyanosis, the upper body is pink or acyanotic, whereas the lower body is cyanotic or blue. Physical examination shows the presence of a continuous murmur, also called as machinery murmur. Continuous murmur means it can be heard in both systole as well as diastole. Cardiac catheterization will show increased oxygenation only in the pulmonary artery, not in the right ventricle or the right atrium. Although surgery is the definitive treatment for patent ductus arteriosus, intravenous indomethacin can be given to close the PDA. Coarctation of aorta is a constriction or narrowing of the aorta. It is of two types, preductal, which is more common, and it is also called as infantile, versus postductal, which is less common and is seen in adults. In preductal coarctation of aorta, the constriction is proximal to the ductus arteriosus. In postductal coarctation, the constriction is distal to the location of the ductus arteriosus. Coarctation of aorta is more common in boys. If it is diagnosed in girls, they need to be evaluated for Turner's syndrome. Physical examination shows a systolic ejection murmur which can be heard at the apex, the left sternal border, and the interscapular area. Coarctation uniquely shows reduced blood pressure in the lower extremities because of the constriction of the aorta and increased blood pressure in the upper extremities, which can even lead to barrianeurysms and intraventricular hemorrhage. The renal blood flow may be decreased, leading to a high renin hypertension. Reduced blood pressure in the lower extremities also clinically presents in the form of weak femoral pulses, radiofemoral delay, and claudication in the extremities. Chest X-ray will show characteristic rib notching, which is seen right under the ribs because of increased collateral circulation. The chest X-ray shown in the slide points to the area where the aorta is constricted. Let's take a look at the cyanotic congenital heart diseases. The two most important CHDs that we need to know are tetralogy of Fallot and transposition of great arteries. Tetralogy of Fallot, or TOF, is the most common cyanotic congenital heart disease. It is characterized by four components. These are ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and overriding aorta. Cyanosis is not seen at birth, but typically about 12 weeks or 3 months after birth. Other symptoms include tachypnea, dyspnea, clubbing, and hypoxic spells, also called as TET spells. Physical examination shows a systolic murmur at the left sternal border. Chest X-ray shows typical feature of boot-shaped heart. TET spells or hypoxic spells can be treated by oxygenation, knee chest position, morphine, alpha agonists, and beta blockers. Surgery is the treatment of choice. It's a definitive treatment to treat TOF. Transposition of great arteries is a condition where the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. Associated conditions are either AST, VST, or PDA, which are essential for survival. Transposition of great arteries presents with cyanosis right at birth. X-ray will show the typical appearance of egg on side. Temporary measures like prostaglandin E1 and balloon septostomy can be life-saving. Definitive treatment is by arterial switch procedure, which should be done within the first 2 weeks of life. I would like to mention briefly the last 3 cyanotic heart diseases. In TAPVR, or total anomalous pulmonary venous return, the pulmonary veins drain all of their oxygenated blood into the right atrium instead of the left atrium. In truncus arteriosus, both the major vessels, aorta and the pulmonary artery, they arise as a single trunk, and there is no clear separation, leading to intermixing of blood, causing cyanosis. In tricuspid atresia, a stenotic tricuspid valve leads to a right to left shunt, causing cyanosis. In order to get a deeper understanding on this subject, I would recommend you refer development and embryology of the cardiovascular and respiratory systems in achievable USMLE. Thank you for watching today's video.